So hi students, hope you're all doing good. In this video, we are going to continue our discussion on hypertensive disorders in pregnancy, right? So we'll see the investigations, okay? So once again, we'll come up with urine examination. So what you'll be able to make out? There will be proteinuria, right? So that means more than 300 milligram of protein in 24-hour urine sample, okay, or a spot urine protein creatine ratio, okay, or PCR, that is more than or equal to 0.3, and a random urine sample that is showing more than 30 milligram per deciliter of protein, and when the urine dipstick shows more than 1 plus, and according to ACOG it is more than or equal to 2 plus. Okay, so any one of the findings, and which is the gold standard? Yes, it is the 24-hour urine sample which is the gold standard. Okay, right? Then we will see the microscopy findings. Okay, so if you see microscopy, because of the endothelial cell damage, okay, that is present in hypertension generally, in case of chronic hypertension, you will be able to see RBC cast. Okay, in case of preeclampsia, you will be able to see granular cast. Clear? Yes. And the next one is blood investigations. Okay. So if you see the blood investigations, what is the first hematological finding we will come across? Yes, very good. It is thrombocytopenia. So how much will be the platelet count? It will be less than? Yes, very good. It is less than 1 lakh. And also because of the hemolysis, what is going to happen? There is increased level of LDH in the serum. Yes, and if you take the peripheral smear because of the hemolysis, the signs of hemolysis like, yes, very good, it is spherocytes. Okay, spherocytes and cystiocytes you will be able to see. Clear? Then if you do the LFT, okay, you will be able to see increase in level of the transaminases, that is increase in level of both AST and LT are seen double the times from its basal value. And the next one is when you do a RFT, that is increased levels of creatinine. Clear? Yes. So we'll check for the fetal condition now. So we'll do a NST, then we'll do a USG. In the USG, we'll check for the fetal weight, fetal growth, then how is the placenta, what is the amniotic fluid index, and last but not the least, your Doppler studies also. Okay. So combiningly, what is modified biophysiological profile? You can combine both NST and USG parameter, that is AFI. Okay, so this can be done. Clear? And remember, so in the Doppler studies, studying about the uterine artery Doppler is important. Okay, so because that is where the changes are taking place, right? So this will be seen mostly in the second trimester than first trimester. Okay, so even if you do a, mostly will not be doing Doppler in a case of pregnancy in first trimester. Okay, but if you suspect for preeclampsia in case of risk factors, and if you do in the first trimester, then most of the times that is going to be normal, because it is the second stage of trophoblastic invasion that is going to be hindered, right? So mostly it will be seen in second trimester than first trimester, and the findings include there can be presence of diastolic notching, Okay, there can be high pulsatility index and there is a high systolic diastolic ratio also. Clear? Right. Now we will see the placenta. Okay, so if we take the placenta, what are the findings we will be able to see? We will be able to see some cystic areas. Yes, first it is a small sized placenta, right? Now in these parameters, in AFA what we will be able to see? That is, you will be able to see oligohydramnios. Okay, and in the scan finding of placenta, if you see, there is a cystic area. Okay, so that will be seen in preeclampsia. Okay, so this is a post delivery picture of the placenta in a case of preeclampsia. Okay, so here we are able to see some avascular cystic space, right? So this kind of space will be seen in a case of preeclampsia, and these are defined as rounded intraplacental infarction hematomas. Clear? Yes, so these are seen in a case of preeclampsia. Next we will go for prediction of preeclampsia. See, remember the risk for recurrent preeclampsia is as high as 35%. Okay, so risk for recurrent preeclampsia is increased up to 35%. Okay, to reduce the effect of maternal and fetal complications, we have to do the prediction. Okay, what is the first thing we will do? Yes, BP measurement. Okay, so that is very important, followed by in USG uterine artery Doppler is important. Okay, and next one is biochemical markers. Usually it is not done clinically. Okay, remember that fact. Only for theoretical purpose we are learning. Okay, so what are the markers we have? Yes, which are going to increase? That is increase in soluble FMS like thyroid. Repeat. That is increase in soluble FMS like tyrosine kinase 1 and soluble endoglin. Whereas which are going to reduce? Placental growth factor and vascular endothelial growth factor are going to reduce. Clear? Yes. Now we will see what are the prophylactic measures we have to offer them. So if we see the prophylactic measures, first important thing you have to offer them is low dose aspirin. Okay. So low dose aspirin means it reduces thromboxane A2 synthesis. Okay, and it maintains prostaglandin synthesis. I hope you remember the pathology in preeclampsia, that is there is increased production of thromboxane A2. Okay, so that is being reduced by this. And also remember, this is given only for women who are at a risk of preeclampsia. Okay, So, there should be either high risk for preeclampsia, like, so the high risk factors include early onset preeclampsia, preeclampsia that is happening in more than one pregnancy, if she is already a known case of chronic kidney disease and she is having diabetes, either type 1 or type 2 diabetes mellitus, or her condition is complicated by chronic hypertension, or she is suffering from any of the autoimmune diseases. Okay. So apart from these high risk factors, we also have some moderate risk factors. The moderate risk factors include nulliparity, more than 40 years old, then pregnancy interval is more than 10 years, BMI is more than 35 kilogram per meter square, then when there is a family history of preeclampsia and when it is a multi-fetal pregnancy. Clear? And remember, among the moderate risk factors, at least 2 risk factors should be present for supplementing low dose aspirin. Okay. So, low dose aspirin means, what is the dose means? It is 75 to 150 milligram per day. Okay. And if you find any of these complications, it is better to start aspirin as early as possible. Before 12 weeks itself you have to start it, and it should be continued till 36 weeks. Okay. Or otherwise, if you are planning the delivery later or sooner, it should be stopped at least 1 week before. Okay. Clear? Yes. And another important supplement we can give is calcium. Okay. And calcium can be supplemented up to a dose of 2 gram per day. But remember, this is given only in patients who are calcium deficient. Okay. Clear? Now, I will tell some of the not recommended things in case of preeclampsia also. Okay. So, you should not recommend the following things. Okay. So, number 1 is bed rest. Okay. So, you should not recommend the following things. First one is complete bed rest is not advised, right? Then salt restriction, low molecular weight heparin or diuretics, then progesterone, then nitric oxide donors, magnesium and antioxidants. Okay. So, no need to give all these things. Okay. Now, we will see the management part. So, management, first we will see management of gestational hypertension. If you take gestational hypertension, what you have to advise is, you have to advise weekly antenatal visits, then you have to do maternal monitoring by checking her BP regularly, and if BP is increased, you have to check for proteinuria, and if needed, signs and symptoms of end organ damage also should be checked. Okay. Then you have to check for the fetal well-being also. Okay. You can advise the mother to see her daily fetal movement count. Okay. Also, you can get a NST, or you can do it as a biophysiological profile itself, okay, weekly or at least once in 2 weeks, and via the USG you have to assess for the fetal growth, AFI and Doppler, okay, and this should be done at least once in a month, clear, that is once in 4 weeks, okay. And when you plan delivery in a case of gestational hypertension, usually, okay, if the BP is more than 140/90 but it is less than 150/100 means you can plan delivery at 38 to 39 weeks, clear. And suppose if it is more than 150/100 means we can plan delivery once they cross 37 weeks, clear, right. Now we will see management of preeclampsia. So if you take preeclampsia, we will see the non-severe type of preeclampsia first, okay. For non-severe preeclampsia, if needed we can hospitalize the patient. We have to do maternal monitoring. What will you monitor? BP should be checked regularly, urine, protein should be checked daily, and also you have to check for the platelets and LFT, but this should be done weekly, clear. Next we will see fetal monitoring. So what and all done? Yes, we will advise a daily fetal movement count, then we will do a NST and biophysiological profile weekly, okay, and you will do USG to assess the fetal growth, AFI and Doppler at least once in 4 weeks, clear. And when you plan delivery in a case of non-severe preeclampsia, and when you deliver in a case of non-severe preeclampsia, delivery can be ideally done at or above 37 weeks if no complications arise, okay, throughout your follow-up. Suppose due to any reasons this is converting into a severe preeclampsia or any other complications are arising, there can be a need to deliver at even 37 weeks, clear, right. Next we will see management of severe preeclampsia. So management of severe preeclampsia, we are going to hospitalize the patient, okay. You have to start the mother on 3 things, okay. Number 1 is anti-hypertensives to control her BP, okay. Number 2 is Maxilf, okay, and number 3 is corticosteroids, right, and especially if the pregnancy is between 28 to 34 weeks, clear, okay. Now how will we do maternal monitoring? So maternal monitoring you have to do, yes, the same thing, daily monitoring of BP, urine output, urine, protein should be there, okay, and you have to even weight, okay, so there will be increased weight because of the fluid accumulation, right, and you have to advise them about the warning signs of preeclampsia, okay, and then you have to send the lab investigations and do the fetal monitoring, clear. And when you will deliver in this case, you will be planning for an immediate delivery if there is a persistently high BP, or it has led to abruption, or there is pulmonary edema. Okay, so this is pulmonary edema. And also we can terminate it immediately if the gestational age is less than 28 weeks or more than 34 weeks. Clear? And we can terminate after giving a course of corticosteroids. Okay, so that means for the action of corticosteroids we will be giving some 24 to 48 hours to act. Okay, so this we will do when, okay, the gestational age is between 28 to 34 weeks, or there is a severe fetal growth restriction, or there is a abnormal Doppler, okay, and there is HELLP syndrome complications. Then when it turns out to be a preterm labor with preterm premature rupture of membranes. Clear? Yes. Now in this case, abnormal Doppler is there means it can be either absent in diastolic flow or reversed in diastolic flow in the uterine artery, right? So in case of absent in diastolic flow, you are going to deliver it at between, So in the case of absent in diastolic flow, you are going to deliver between 33 to 34 weeks. Okay, so 33 to 34 weeks. And in case of reversed in diastolic flow, you have to deliver between 30 to 32 weeks, right? So between 30 and 32 weeks. Clear? And also remember, we are going to choose only normal vaginal delivery, and cesarean section is reserved only for obstetric indications or in a case of fetal distress, okay, because there is FGR complication also, right? So because of that, okay. Now we will see the antihypertensives. Okay. So antihypertensives, if you take, the most commonly used antihypertensive in pregnancy is labetalol. Okay, so this is the drug of choice. If you take it as a alpha and beta adrenergic blocker, okay, dose is between 100 milligram BD to 800 milligram BD, okay, and if there is severe hypertension, then you can give even IV labetalol at a dose of 10 to 20 milligram IV over 2 minutes, okay, and this can be given up to 300 milligram, okay, or otherwise you can give some 20 milligram IV loading dose followed by infusion of labetalol over 1 to 2 milligram per minute. Clear? Right. And the next drug is nifedipine. What drug is this? Yes, it is a calcium channel blocker. So you have calcium channel blocker. Okay, so the dose of the drug is 10 to 20 milligram orally. Okay, and you have to supplement this every 6 to 8 hours. Okay, suppose if there is a severe hypertension, okay, we have to start 10 milligram initially, okay, orally. That will be followed by 2 more additional doses. Clear? And this can be given up to 30 milligram per day. Clear? Yes. Next one is hydralazine. If you take hydralazine, What kind of drug is hydralazine? Yes, it is a peripheral vasodilator. So, it is a peripheral vasodilator. It is used in severe hypertension. Okay, it is given at a dose of 5 to 10 milligram IV over 1 to 2 minutes. Clear? Next drug is alpha methyl dopa. So, if we take alpha methyl dopa, it is a centrally acting drug, reduces the sympathetic outflow, and the dose of the drug is 250 to 500 milligram 6 to 8 hourly orally. Okay, and this can be given to a maximum of 2 gram per day. Clear? Right. Now, if you see the management of chronic hypertension in pregnancy, first thing you have to do is, yes, you have to stop the angiotensin converting enzyme inhibitors or ARBs if she is already taking. Okay, so stop the angiotensin converting enzyme inhibitors and ARBs. Okay, you can supplement them with other anti-hypertensive medications. Okay, so other anti-hypertensive medications can be continued. Okay, and if needed, dose adjustments can be done. And suppose in case if you want to change over or add drugs that are used in pregnancy like labetalol or nifedipine, that option can also be kept in mind. Clear? And you have to monitor via USG for the fetal morphology and fetal biometry and all the other parameters, okay, including AFI, Doppler, okay, etc. Then regular antenatal care you have to give, and most of the time in case of chronic hypertension, delivery at term can be done if it is not complicated by preeclampsia, right? Next one is when preeclampsia complicates chronic hypertension. So, preeclampsia that comes superimposed on chronic hypertension. Now, this type of presentation is more common when there is high obesity, okay, or the patient has a history of smoking and increased BP at the very first visit itself. Clear? Now, for these patients, we can do induction of labor around 37 weeks of gestational age. Clear? Yes. Next, we will see about eclampsia. If you take eclampsia, what is eclampsia? That is convulsions in a woman with preeclampsia. Okay, so this can even present acute and it will be associated with high BP and proteinuria. Okay, so usually 2 to 3% of the women, okay, with severe preeclampsia can go for eclampsia. Okay, if you take the risk percentage, okay, in antepartum period, the risk percentage is around 55%, okay, whereas in the intrapartum period, this is around some 30%, okay, and in the postpartum period, within 48 hours of delivery, it is 10%, and after that, okay, after 48 hours, it is 5%. Clear? So, remember the risk is more in the antenatal period. Clear? So, what is going to happen actually? Why the patient is going to throw seizures in a case of preeclampsia? See, there is loss of autoregulation. Okay, that will be leading to segmental vasoconstriction and dilatation of the cerebral vessels. Okay. So, that will be leading to, yes, very good, that will be leading to hemorrhage, ischemia and necrosis. Okay. So, finally, there is also exudation of fluid that will be presenting as edema. Clear? Now, if we see the clinical features in eclampsia, so the clinical features include premonitory stage or tonic phase, clonic phase, and finally she can end up in coma. Okay. So, we will see what are these phases individually. Okay. In premonitory phase, she will be complaining of all the warning symptoms. Okay. So, that is, there can be headache or blood division or diplopia, yes, photophobia, epigastric pain, right upper quadrant pain and confusion. Okay. And in the tonic phase, what is going to happen is the tone is going to get increased. So, that means she will be presenting with rigidity, spasm of muscles. Okay, there can be twitching of the muscles and there can even be frothing from the mouth. Clear? And in case of clonic phase, what is going to happen is muscles are going to contract and relax alternatively. Okay, so muscles contract and relax. Okay, in this phase only tongue biting can also be seen and accidental falling can also happen. Clear? Okay. Now, coma state actually varies. Okay. Right. Now, what are the other associated changes that can happen in eclampsia? Okay. So, other associated changes. Clear? So, number one, there is going to be hypercapnia. Okay. Then hypoxia. There is going to be lactic acidosis, oliguria, proteinuria, even hematuria. Then for the fetus, because of the hypoxia, there is going to be fetal bradycardia and sometimes high fever can also be seen. Okay, and this is considered to be one of the grave signs if it happens in a case of eclampsia. Okay, so in this case, if you take the maternal mortality, it is around 2%. Okay, the perinatal mortality is high and it can be anywhere between 25 to 30%. Clear? Right. So, how will you manage a case of eclampsia? So, management, first you have to do resuscitate the patient, then put her in left lateral position for two reasons: to prevent tongue from falling back and to prevent aspiration. Clear? Next is you have to give a mouth gag also to prevent injury to the tongue. Okay. Suppose if any vomiting or secretions are present, that should be aspirated. Okay. So, vomiting and secretions are aspirated. Okay. Then you have to also catheterize the bladder. Okay. Then urine output should be monitored. Okay. Magnesium sulfate is the drug of choice in management and prevention of preeclampsia. Okay. We will see the mechanism of action of the drug. Number 1, it blocks the NMDA receptors in the brain. Okay. Number 2, it decreases acetylcholine levels in motor nerve terminals that reduces neuromuscular irritability. Okay. And it decreases it reduces acetylcholine levels in the motor nerve terminals so it reduces the neuromuscular irritability. Okay. Then it reduces the intracranial edema also, and one thing it causes is vasodilation. Okay. So, in the cerebral vasodilation, it reduces hypoxia chances, and while doing a peripheral vasodilation, especially in the uterus also there is vasodilation caused. So, it will be causing increased blood flow and increased blood flow to the kidneys also. So, that means it causes diuresis. Clear? And it also has a depressant action on the uterus. That means it can act as a tocolytic also. Clear? And what is the other use of MAGSULF? It can be used in neuroprotection. Okay. Clear? Okay. Now we will see what are the indications of giving MAGSULF. So, indications include number 1, eclampsia. Number 2, we can also give it in severe preeclampsia to reduce the seizure threshold. Okay. And suppose if there is preterm labor activity, then decrease the uterine activity. Okay. So, all these things can be done. Now, what are the contraindications of MAGSULF? Contraindications include if it is a case of heart block, suppose she is in active labor, okay, or there is impaired renal failure and It's a case of myasthenia gravis. Clear? See how we are going to give MAGSELF. See, we have two regimens. Okay, we have a IM regimen called as Richard regimen and a IV regimen called Zuspan regimen. Okay, remember 1 ampule of MAGSELF. Okay, if you take 1 ampule of MAGSELF, it contains 2 ml of MAGSELF and in that you have 1 milligram of the drug. Clear? So, 1 ampule contains 2 ml and in that 2 ml 1 milligram dose of the drug is present. Clear? If this is clear, we can go to the IM Richard regimen first. Okay? We will see the loading dose in IM regimen first. Okay? So, if we take the loading dose, it should be given both IM and IV. Okay? So, the IM loading dose, we are giving 10 gram of 50% solution. Okay? So, this can be split up and give us 5 grams in each buttocks. Clear? And if you take the IV loading dose, this is given as a 20% solution. Okay? And the dose should be 4 grams. That means, how we are preparing this 20% solution means, normally it is 50% solution. Okay? How we are preparing this 20% solution means, we will be taking 20 ml syringe, in that 12 ml of NS we will take and remaining 8 ml of MAGSELF we will take. So, it is 4 ampules because 1 ampule contains 2 ml. Can you understand? So, this preparation is 20% solution and this will be given at a speed of 1 gram per minute maximum. Okay? So, it should be given very slowly. Okay? And it shouldn't exceed 1 gram per minute. And in the Zuspan regimen, what we are going to do is, we are going to give a 4 gram IV loading dose of a 20% solution followed by 1 gram per hour of IV infusion. Okay, and remember, whenever giving loading dose, you have to give it very slowly, 15 to 20 minutes at least you should take, and it shouldn't exceed the speed of 1 gram per minute. Clear? Yes. Now, till what time you will be continuing this MAGSELF regimen? So, this should be continued 24 hours after last convulsion in a case of eclampsia, okay, or delivery. Okay, so whichever is later, you have to choose that. Clear? Yes. What are the side effects of using MAGSELF? Side effects, if you see, there can be nausea, vomiting, diarrhea, okay, or flushing, breathing problems, okay. Then confusion can be there and reduced uterine contractions because it is a tocolytic, right? So, this can also happen. Clear? So, after this you have to give a maintenance dose, right? So, the maintenance dose in Zuspan regimen should be given as IM injection 5 gram that of 50% solution every 4th hourly. You can give it in alternate buttocks. Okay. Now, if you come to IV Zuspan regimen, the loading dose you give is, now coming to Zuspan regimen, you give 4 gram IV loading dose followed by 1 gram per hour of infusion. So, remember, while giving loading dose, you shouldn't give it in a very rushing manner. Okay, so it should be given in a time over 15 to 20 minutes and the speed shouldn't exceed more than 1 gram per hour. Okay, so that is the thing. And if we see the side effects of using Maxilf, there can be nausea, vomiting, diarrhea, okay, or favorite side effects, right. Then there can be flushing, there can be breathing problems, okay, and confusion and reduced labor pains because it is a tocolytic. Clear? So, if you give Maxilf, very important thing to do is monitoring. Okay. So, monitoring, how will you do? See, Maxilf has a therapeutic range. Okay. So, if you take the therapeutic range of Maxilf, it is between 4 to 7 milliequivalents per liter. Okay. So, this is the therapeutic range. Okay. So, you have to monitor 3 parameters while giving Maxilf. You have to monitor the knee jerk, you have to monitor the urine output, as well as you have to monitor the respiratory rate. Clear? So, knee jerk reflex should be present, okay, and urine output ideally 100 ml in 4 hours, or you can also keep 30 ml per hour. Clear? And respiratory rate, if you take, suppose it is becoming tachypneic, that is more than 12 breaths per minute, then the toxicity has happened. And remember, if the levels of Maxilf are crossing more than 12 milliequivalents per liter, then respiratory depression can occur. Okay, and if it is going to cross more than 15 milliequivalents per liter, then respiratory paralysis can occur, and if it is crosses more than or equal to 24 milliequivalents per liter, then cardiac arrest can also occur. Okay. Suppose if there are signs of Maxilf toxicity, okay, signs of Maxilf toxicity is present, then first thing, discontinue Maxilf, okay, and then administer antidote. Antidote for Maxilf is calcium gluconate, okay. So, that should be given at a dose of 1 gram, that is a 10% solution of calcium gluconate can be given in a 10 ml ampule, and this can be administered over 10 minutes. Clear? Suppose even while giving this dose, the patient is going for seizures, means you can administer even 2 gram maintenance dose, okay, additional 2 grams. Clear? So, in this case, we are giving Maxilf, but still the convulsions aren't settled and it is proceeding more than 15 minutes, means, okay, you can give another dose of Maxilf, that is 2 gram IV can be given, okay, in 20% solution. If the seizures are not controlled, okay, you can even give an additional dose of 2 gram of 20% solution as an IV dose over 15 to 20 minutes. Clear? Right. So, with this we are completing the discussion on Maxilf, but in this video we are going to discuss about HELLP syndrome also. With this we are completing the discussion on Eclampsia. I want to discuss about HELLP syndrome also in the same video, okay. So, if we take HELLP syndrome, this is more common in women who are young as well as who are multiparous, okay, and this can occur in 0.1 to 1% of pregnant women, okay. And if you take the risk is more in HELLP syndrome than preeclampsia, okay, than preeclampsia for liver injury. So, there can be hepatoma formation and rupture of the capsule and hemolysis and also for DIC. Clear? Usually this develops between 28 to 36 weeks of gestation age. Clear? So, we will see the lab criteria for HELLP syndrome. If you take the lab criteria, there is microangiopathic hemolysis. Okay. So, when blood cells are going to pass to the highly damaged endothelium, they are going to get lysed, right? So, number 1, there is RBC fragmentation. So, what are the findings we can have? Yes, it is cystocytes, reticulocytosis, anisocytosis, then helmet cells. Okay. Then because of the RBC destruction, there is increased level of LDH also, and these levels can be as high as more than 600 units per liter. Okay. And hemoglobin levels are reduced because of the destruction and heme is released. So, this will be converted into bilirubin, and due to that jaundice can be a presentation. Okay. And you have heme, that is unconjugated heme and conjugated heme, right? So, this unconjugated heme only, it is converting into bilirubin. This conjugated hemoglobin is going to combine with haptoglobin, and this hemoglobin haptoglobin complex is going to be cleared by the liver. Okay, so it will lead to reduced levels of haptoglobin also. Okay, and there is definitely thrombocytopenia and the count is less than 1 lakh. Okay, so if you see the conditions in which thrombocytopenia occurs in pregnancy, means it can be gestational thrombocytopenia or ITP or preeclampsia or HELLP. Okay, and remember, in HELLP, serum uric acid is also raised, serum liver markers, that is AST and ALT, are also raised. Okay, continuing after hypoglycemia. So, other than that, you also have serum fibrinogen levels reduced less than 30 mg per deciliter. See, in some cases DIC can set in, so you have to check for your PT, APTT and fibrinogen. Okay, if serum fibrinogen levels are less than 300 mg per deciliter, then DIC should be suspected. Okay, at the same time, sometimes D-dimer can be positive. Clear? Now we will see classification of HELLP. Okay, so we have a classification called Tennessee classification. So it is Tennessee classification. We will be using 3 parameters. Okay, first one is platelet count less than 1 lakh. Second one, AST levels are more than 70 international units per milliliter, or LDH levels are more than or equal to 600 international units per milliliter, right? And next one, this is also more than or equal to, right? And next one is hemolysis, signs of hemolysis in peripheral smear. Clear? Now in this, okay, if 2 out of 3 criteria are present, it is known as partial HELLP. Okay, if all the three criteria are satisfied, it is known as full HELP syndrome. Clear? See, if the diagnosis is full HELP syndrome, then there is a high risk of DIC. So, you have to expedite the delivery and it should be done within 48 hours of diagnosis. Clear? Whereas in partial HELP, conservative management can be tried. Clear? So, with this, we are finishing the discussion on hypertensive disorders in pregnancy. So, until we meet in the next video, take care, happy learning and bye-bye.